It's a great privilege now to have a very dear friend at Lumen Global, Dr. Tan Huay Cheem from Singapore. Huay Cheem, welcome to Lumen Global.
Thank you.
I cannot think of more people in the ASEAN region than you, who has made a massive difference in STEMI interventions in the region and possibly beyond. I recollect your first visit to Lumen Global in Miami, I think 2009 or 10,
10.
and it's been a wonderful partnership. And I have attended many of your AICT meetings and just world-class endeavors. And thank you for your numerous contributions to STEMI interventions. I also remember very vividly that almost a decade ago, Singapore as a nation was doing door to balloon time of 67 minutes. What even we were struggling in the United States with the efficient Singaporean, that was your title, I think, at one of the Lumen Global, was a not really an insurmountable challenge. But we've come a long way. Today, maybe one doesn't even need door to balloon times. There are better quality indicators. Does that seem correct?
Samir, first of all, it's a tremendous privilege and honor for me to be part of the Lumen Global. And having known you for the last decade, I have also learned a lot from you. I think from a patient's perspective, door to balloon time is an initial good matrix to measure how well and how efficient the hospital is in delivering a primary PCI care. But to me, ultimately, a patient will benefit if we can look at the onset of symptoms to balloon time, because that will really determine the total ischemia time that the patient is having, and which ultimately is going to determine his outcomes and well-being. So I think the traditional door to balloon time of 90 minutes, at this point in time, we are achieving about 47 in my center. But as a nation, we feel that we should now be moving to a 60 minutes in accordance with ESC guidelines. But more importantly to me is how can we get the patients who develop a symptom of heart attack to quickly go to the hospital and then have the balloon angioplasty performed as part of a primary percutaneous coronary intervention. Here we can look at the ESC guidelines. In fact, ESC guidelines have dropped this concept of door to balloon time. We talk about patient delay as well as system delay now. So how long does it take for the patients to have a phone call to an emergency service? That is the patient delay. Once a first medical contact has been established, the challenge now is for the healthcare system to bring the patients to the hospital and have the balloon done within 120 minutes. So 2 hours time frame is what we are looking at right now in terms of first medical contact to a balloon time.
Absolutely, completely agree with the approach. I think most centers in the United States are feeling exactly the same way, but the logistics are very difficult, particularly where it comes to the patient awareness component. Now, again, I do not know of more populations more efficient or organized than Singapore, and there is much the world can learn. So tell us some of the ways how you've been able to get the patients more alert.
I think first of all, you need to get your data correct first. So when we look at our own Singapore cardiac database registry, we realize that the time of symptom to balloon time of less than 120 minutes only occurs in about 48% of patients. Well, that means almost only
which is very good, by the way.
Which is good, okay. But there is another nearly 50% of patients who comes after the 24 hours, which we feel could have been better improved. So I think there are several strategies here that we are undertaking. I think foremost of which is a continuing public education effort. So we continue to go to the media, we continue to work with the grassroots organization, we continue to work with the various healthcare agencies to try to reach out to the population that should there be a suspicion of any heart attack symptoms, please contact your emergency medical service at the quickest possible time.
What's the role of the societies in this?
I think the society has got every part to play here. I think the society has to be mindful of this idea that time is the essence, time is muscle, and time is life in anybody with heart attack. So it has to be a concerted collective effort here in trying to reach out to everybody here with regard to the urgency of the care delivery in this particular condition.
You are so familiar with the challenges of STEMI interventions in India, and they are genuinely tough challenges. I mean, this is the word insurmountable doesn't even get relevant here. If you look at the masses, the infrastructural issue, the financial issues, the traffic, just a situation of complete chaos which sets in. What could India learn from the experience of Singapore, plus the lessons you've gained at AICT?
I think Lumen Global has taught us over the years many, many important principles. And I thought there are three areas by which perhaps a developing country like India can learn from. One is that the principles of reduction of door-to-balloon time is actually quite consistent throughout the world. Having good protocol, having hospital leadership and so forth, that is without question. The second thing that we have learned for over the years is that we need medical leadership here. And medical leadership oftentimes has to come from a hospital level or a regional medical healthcare leader. Someone like yourself who champions this whole idea of a good, timely care delivery systems for patients with STEMI is of paramount importance here. And the third here is that we need to create a whole environment, be it in the hospital or in the healthcare services system, to push for these particular systems to be efficient. So it takes effort, not just at the individual hospital level, but the society, the healthcare services, the healthcare system, and the government as well.
Huay Cheem, completely agree with all these three approaches. Let's talk about, for a moment, about STEMI networks. We recently wrote an editorial where in several developing countries, and notably in India, there is a lack of organized STEMI networks. How does, and again, no two countries are similar. The challenges are so unique. How does one create a STEMI network in India?
I feel, again, the same principles will apply, that there need to be a will to get this going, and that will has to be championed by a medical leadership.
What about how does one address both the quantitative and the qualitative lack of ambulances?
So on these matters, I would say that every healthcare system is quite different. Every healthcare system funding is very different. Right. So in a developing country like India, I would imagine some kind of a health budget will have to be allotted to provide for such emergency healthcare services.
And again, you don't need a fancy level 1 ambulance for every situation, but the basic ambulance care with the telemetry and an ability to resuscitate is critical.
Yes.
Huay Cheem, we've often been talking about several other quality initiatives which Singapore and you in particular, both in and outside AICT have been championing. Educate us some more about what other educational initiatives are possible, quality initiatives for STEMI.
Samir, we have been actually very excited from this new concept of value-driven outcomes that we are proposing in Singapore.
Even for STEMI?
Even for STEMI.
Fantastic.
The problem with healthcare challenges now is that nowadays we don't know how much of a healthcare value that we can actually apply at the individual patient and institution level, and how much of a healthcare outcomes are we getting for every healthcare dollars that we spend on. So I think value-driven outcomes, which value broadly can be divided, can be said to be a quality divided by ratio, by the cost. So value is quality divided by cost. So what we want to do here in this video approach is that, first of all, we want to be able to quantify and allocate the care of cost and quality measure to each individual patient encounter. And the second thing we want to do is we now want to equip all physicians or doctors looking after patients the necessary tool and information to teach them what is value care, to tell them what is their variance and the best practices that is available now with regard to the care of patients with STEMI, and finally also to try to at least teach them to how to achieve health and cost optimization. So with all these words, what does it really mean? Actually, it means two things. It's how do we improve quality with cost rationalization, and how do we achieve a consistent value outcome with minimal variation? We are not talking about keeping the cost to the lowest possible, because if you make everything cheap, at some point in time, your quality is going to be affected, and that is not value. So value, what we do now is that we measure 4 quality indicators, and then we look at the cost needed to achieve these 4 quality
Tell me the
indicators.
4 quality indicators.
So the 4 quality indicators for STEMI specifically will be the clinical quality and safety. By that, I will mean in-hospital mortality, 30-day rehospitalizations, and the length of stay. The second quality we look out for is the appropriateness of care. Is this patient getting the evidence-based medicine, aspirin, beta blockers, statins, and so forth? The third quality indicators that we look for is patient-reported outcomes, which is not so relevant in STEMI patient. And the fourth part of which we often forget, is the patient experience satisfaction. You may do everything is correct, but patient don't feel as though that they're happy or satisfied with the service. And then with these 4 quality indicators, we now want to see what is the cost in delivering this quality service.
Almost all the parameters of the approach, the VDO, has been put into effect in every PCI center in Singapore?
No, actually it's initiated at my hospital.
Fantastic.
And we now serve as a new model of care. And once we think that this is going to work for the nation, we will roll it out to the rest of the country.
So let's take it into the practical step. Christopher Granger, I give him so much credit. He has always mentioned about the importance of data and collection of data.
Correct.
And you know, systems will tell you, look, you know, we agree with the feeling that you need data, but it requires manpower, it requires resources. Now you moved a further goalpost even more by, you know, putting in 4 more quality initiatives, video. Yet there is absolutely no doubt that you know, simply looking at the outcomes is not enough. Simply looking at the lowest most cost is doesn't make any sense. So all the quality driven initiatives require even more data collection, or is it really more in our minds, and once you get a systematic approach to gathering this data, it becomes easier.
Indeed, big data analytics is the way to go now.
Fantastic.
To actually guide us in terms of what is the best health outcomes that we can actually achieve. So I think every hospital, at least in NUH, maintains a registry of data for all patients coming in with STEMI, from his demographics to his outcomes to the cost of treatment and what sort of treatment and so forth. All these are systematically collected. We can have a system analyst that can take out all these quality indicators that I just told you, but we will always have to have a doctor, a clinician's input to make sense of all this information. And that's why I think every department or cardiology need to have a clinician champion in this value-driven
Absolutely, absolutely fantastic. It's fascinating. I have no doubt the relevance and what you have really, you have so significantly elevated in my mind. I was looking forward to Holger Thiele, and what he has achieved in the management of shock really is the high point of the meeting. What I think you have raised, Huay Cheem, is something which comes as such a fantastic initiative, which I'm sure is going to resonate over the next 48 hours. Simply, you know, on one hand, you know, I come here and I look at countries struggling with it, and there are many. We'll be hearing from people from Cambodia and Myanmar and Bangladesh and India. They have these challenges. Yet, I think somewhere around the way, you start even putting in the quality measures. You know, one of the areas it makes complete sense to me, and I have noticed that with our work in telemedicine in Latin America, is that further funding and financial support is restricted because there are questions. Look, you know, where is the quality? Where is the data? So I think your work is most relevant. I hope to learn more about it, and thank you so much for Huay Cheem, for your wonderful years of support to Lumen Global, and it's a pleasure and joy welcoming you to the meeting.
Thank you very much, Samir.